Okay, good morning. This is Mike Janssen, and I'm very excited to organize and be part of the participant today for this journal club, virtual journal club. We selected a great, I think, portfolio of different articles. And for those of us that are a little different phase of our career, we do the maintenance of certification for the American Board of Orthopedic Surgery. And each year you have to pick a series of articles. Some of them have not yet been published, but have been accepted for publication. There's one article each year that is required for all orthopedic surgeons to have to read to take the exam. And the first one out of the chute is this particular article on the AOA critical crisis. And it has to deal with the management of stress in the orthopedic family, avoiding burnout, achieving resilience. And I thought this would be a great article to kind of throw up some of the key issues that we should all be thinking about. Just last month, there was a publication in the U.S. News upon the most stressful jobs in the U.S. And that came up, of course, as one is surgery, being an airline traffic controller, an airline pilot. And for some reason, they put an attorney in there also, which was a little surprising. But I think that really brings us up to what really stress is a double-edged sword. I'm struggling with my computer a little bit that I can't find the text. Oh, there we go. Good, thanks. So I think one of the key things with this article that we can discuss is it was a national survey put out in the American Orthopedic Association magazine. They surveyed about a little over 600, and they didn't just do the residents, but they also did attendings and spouses of residents and spouses of attendings. And it was put together through a grant through the ORI, or the Orthopedic Research Foundation, looking at some validated instruments. One of the really key things, I think, is that I don't get involved in selecting residents. I work very closely with fellows, but I don't know how the resident program directors are selecting doctors that they think can handle the stress as well as we can, how well they do on boards and a variety of things, since we realize it's one of the top professions. I made an error and I hit a button and okay, there we go. Can you help me advance it? There we go. So when you first look, this is the demographics of what was in this. It kind of gives just an overview of the total number of people involved in this particular study, which was the residents primarily, and then you had attendings, and then you had spouses of each at the same time. What they really found was that of the total number of surveys in this, a little over half were residents, 30% were working resident spouses, about a quarter of them faculty. And this came up even actually on our MOC exam, is among all of the people in this category, which are the residents or which of those that were surveyed have the highest rate of burnout? It was a PGY2 level. That came up on the exams of the people that I know. And female residents had a higher incidence. And the larger training programs, I think that'll be a good discussion point. Training programs that had more than 6 residents had a higher incidence of burnout than the more boutique programs with less than 6 residents. And there's different components of burnout. Number one is depersonalization, emotional exhaustion, and lack of personal achievement. And you can see here, the big spike was this depersonalization is probably the biggest of the 3 components of overall burnout. The results of this study was when you really take a look at a variety of the psychological stresses, 80% of the residents felt that the sacrifices that they were achieving to be a resident were worthwhile in medicine. What's really scary, though, is 1 in 5 residents were at that point questioning whether the sacrifices they made to get through their residency was actually worthwhile. I think that's a big key. There was an interesting study, as most of us that are further in our career, we didn't have this resident work restrictions of 80 hours a week, but there was a direct correlation of burnout with this component. Some of the other key things here is that when you look at the burnout and you look at what it is that's causing this, some of it's just financial concerns, the overall stress, angry, irritability, sleep deprivation, and all of these were somewhat problematic. As we see more and more incredibly successful women in medicine, they dissected this out, that the female residents had slightly higher psychological distress. They had issues of about a quarter of them had reported some sort of either sexual harassment or sexual discrimination. And the surgeons that were further along in practice, that means faculties that were less than 10 years, tended to have more emotional exhaustion associated with it too. They also dissected out the spouses, both of the spouses that were making sacrifices for residents, as well as that of the attendings, and looking at the groups that were most risk. Again, larger training programs, female residents, spouses, and PGY2 were clearly the worst. Let's go back one. This is really important because I've been in practice for a little less than 30 years, and we all know people in our community or in our practice that everyone has concerns of, and we're always afraid to say something if we have what's an impaired physician. And the AMA definition is the inability to practice medicine with a reasonable skill and safety by the patients with their physical mental illness, and that can be either alcohol or drug dependency. The risk of this is burnout, depression, substance abuse, disruptive behavior, and medical errors. And so I think we all have to, as both looking in the mirror, looking with our colleagues, and looking at the people in the community to help identify some of these warning signs of both depression, burnout, financial stress, and try to help balance what's a major impact in our career. Some of the big warning signs is about 14% were shown to have alcohol dependence among these physicians. 70% of them were treated successfully. And in Colorado, we have a great program where people can go to, and it's supported by most of the hospital staff. And a lot of times when you find a disruptive physician, unless there's a true behavioral issue, it is often related to one of these key factors. This article gave a few algorithms that the most important thing is you got to recognize it. You have to have a formal evaluation program, either in your clinic, in your residency, or your fellowship, and you have to have some sort of formal intervention to be able to help do that, to be able to go through. Whoop, back one more slide. And the last slide here I have is, what was the real tips out of this? Well, you have to accept that all of us are at risk because we chose to go into this particular profession. And you can't ignore the obvious things that create the stress, the behavior that occur. And you have to try to find a few pearls. We all find different things. I love different hobbies. I like to multitask. And it says here, if you really have a companion in your practice and you can, in your life, and you can spend at least 90 minutes with them, it says in here, have regular engagements, and really rely on your partners and your family and have a lot of balance, gives you the best chance to avoid this burnout issue as it goes through. I think I see more physicians retiring earlier today than probably ever in the last few decades. I think that was why I thought this was a really great key article. Okay, how come I'm not hearing anything here?
Mike, can you hear me?
Yes, now I can hear you.
Oh, yeah, you're probably not hearing because nobody said anything. But that was a good article to lead off with, Mike. And it's probably something that was ignored in traditional programs. You know, it was, the snap the whip and work hard. And it was the guy who complained was like the weak link and the wimp in the program. But obviously times have changed and people realize that there's a work-life balance, which was a term that we never heard as residents. And, I think we're past the tipping point where people thought that was a silly idea. And now I think everybody's kind of getting on board that the younger guys are smarter than we were. So I think this is a very good kickoff article. And it's something, we've seen a lot of our colleagues exit the field earlier than they probably should have because they didn't recognize that there's stress in it. So thank you for bringing this article out in the open.
Mike, I have just a question and an observation. So when we all trained, most of us on the panel sitting here, we didn't have any limitation of work hours, and now we do have work hours. And I don't know, actually, a lot of our colleagues, at least in our generation, that had burnout. I know that people retired early, and I don't know if it's a generational thing, if it's the way our training is. I mean, certainly the way it is today, I think is much better. And as Jack said, to have a balanced lifestyle and not devote your entire career and life to medicine and ignore your family. I mean, any observation? You are the epitome of anti-burnout. You have so many outside interests, and I admire you. And I think that you're probably about 200 years old with all the things you do.
It's, everybody finds something different. For me, I like to have different hobbies and professions. And so I can do one of them for 3 or 4 days at high levels of intense, and then I move on to something else. I realized during this COVID more than anything that I cannot retire. Because when I couldn't get up and go to work every day, even though I had these other things to do, I realized at this phase of my life, there's just no way that I'm ready for retirement. But I hear some of my friends and they want to quit at 60. And I'm always admired to see how great people's talents are that they can carry on for many more decades throughout that. I think this article is one about burnout. The second one, which would be great, is when do you recognize it is time to retire and it is time to maybe not, you don't have the hand-eye coordination of that as a surgeon. And we don't have good skills for the judgments for that either.
Maybe one comment on this, Mike, your perspective and anyone else on the panel. With respect to the burnout, is there a nature versus nurture phenomenon? Because we all know some people strive on this kind of stress and actually rise to it, yet others buckle. Is that a genetic component versus the environment that they're growing up in?
Well, I don't know. I'm not a psychiatrist. I would assume it's a combination of both, like some things. But I guess I would twist that back and ask you, do any of the programs help select physicians to become surgeons that can handle this level of stress? I mean, or are they picking them out on their board scores and they're picking them out, on the papers that they wrote? But I'm sure that they must be higher levels of picking out who can be an air traffic controller and a pilot and a variety of those things on stress. But I just wonder whether any program directors spend any time trying to figure out who can handle the stress to prevent medical errors and to prevent this issue of burnout.
Or do we self-select?
Yeah, maybe.
I would jump in.
I don't know.
Mike, those are good points. I'd jump in. I have the perspective of, during my residency, going into my fourth year is when they instituted the 80-hour work week. And we actually calculated the amount of hours that we worked, and we were working about 100 to 110 hours a week. You'd spend almost, 48 hours on call, basically, almost 72 hours sometimes. It definitely helped a little bit, but there are also, it's challenging to run an orthopedic service when you make it, hey, here's your cutoff, and it interferes sometimes with your education. But I think it was a good thing overall when I look back at it. There's definitely different levels of people. I think it takes all kinds of people. Some people do, manage stress better and they're better equipped for it. But I do think that we need to be able to talk about it. I think that's the point of the article, and making it, something that everybody has to read, is to be more comfortable about talking about, hey, I'm struggling here. Right before the 80-hour work week, we had one resident, my chief, and one guy didn't show up, and he's like, this guy better effing be dead. And what happened is we sent the police over there. He was dead, and you don't recognize it. Nobody talks about it. And all of a sudden, after the fact, that's when everybody wants to talk about it in the program. So I think if we're proactive, we can identify some of these people. Maybe early on in the residency, they can switch to different residencies that match their personality better. So I think talking about it's good. So with that, I'll turn it back over to you.
Yeah, Mike, look, from the other end, I didn't just go through it. My daughter just graduated med school, starting a surgical residency, and it was the same process as when we did it. There's absolutely no discussion regarding stress, burnout, nothing psychological in that whole interview process. And that's what I talked to her about is, what it's really like to be a surgery intern. Get ready. There's going to be, besides the physical, the mental stress.
But to that point, has the 80-hour work actually reduced the stress? Is there any data on that? So Jason, you brought it up. I'm assuming this data was before the 80-hour week. So now that it's in, it would be great to see has it made any difference. But my suspicion is I doubt it. Because I'll tell you why. It's also amazing to me. We are the only profession that does not have an annual psychological evaluation. Pilots have it. Military, Navy all have it. It's time we did it somewhere along the path, right? Residents or medical students never get it. And to your point, Jason, that's how you probably pick up something before. Hopefully. But we don't have it.
Neil, that would eliminate half the orthopedic surgeons and 2/3 of the neurosurgeons in the U.S.
That'll be true.
Well, Neil, you bring up a good point. If you were a pilot for any commercial airline, you have to go through the simulators every year. Check you, and I'm sure they're measuring your stress and how you respond, everything else, and we don't do that.
We don't do it.
We will.
I agree. Let's go to the next article and see what we have left.
All right, I guess it's me. Basically, this was, a COVID paper, basically looking at how, what's the philosophy behind trying to manage your residence workforce and keep people safe, basically. So how do you manage that work-education dichotomy in a residency program during this pandemic? Let's see. This isn't advancing for me. Let's see if I can do it. There we go. So again, the management and education of the resident without crushing them, and I think we talked about that with Mike's article, is, how do you achieve that balance, give them appropriate education without harming the resident during this time, given the experience, but how do you give somebody a clinical experience when you're worried about them touching a patient, being exposed to a patient, being exposed to the hospital environment? So basically, this is an article that came out of Atlanta, and they came up with 5 pillars of basically strategy and how to come up with a program or a way to teach your residents but keep them safe. So they felt like the first thing was, number one and utmost is patient and provider safety. Second is ongoing provision of necessary care. So still be able to provide at least absolute necessary care, not the elective surgeries. And how do you differentiate that? How do you make the system sustainable? That if there is a epidemic in the program, how do you keep everybody safe around that to still keep the system going? You can't have it completely collapse because everybody's infected. Basically, you have to have tolerance and ability to flexibility around this. So I guess it's more like the adaptability. It's kind of like the Boy Scout motto, being adaptable in times of crisis. And then preservation of your command and control. I guess that's make sure that the chairman stays healthy. But basically, the leaders of your program, it doesn't necessarily have to be, the chairman, but there's certain faculty that are definitely the leaders of the program and trying to keep them in a leadership role, but keep them safe in this time. So what they set up basically was 2 teams. They cycled basically every 2 weeks. They remained distinct, and there was redundancy. So team 1 had basically a mirror person on team 2. And, when you were on basically some of the active teams, you had, ER subcall teams, guys who would go into the trenches, and that's all they would do over that 2 weeks. And you keep them separate from the guys who are going to be in the operating room or the guys who are going to be in the clinic during the active hours, basically. The most important part was limiting, just to essential care. So basically they talked about, tumor service, trauma service, and maybe, neurologic, service in regards to neurologic deficits. So basically the first team was the Didactic Education, which I think most of us can understand because we're on this today, is that you can do it basically, through Zoom and through all these interactive things. But basically they would do a daily 1.5 hour collaborative faculty-led interactive kind of education program. So that equal to about 7.5 hours per week. Then you'd have an interactive question-based learning discussion with a faculty or with a chief resident or a higher level person, but it'd be interactive and together. And then they had an online orthopedic curriculum that was kind of a self-study, and they had to log in for certain hours over the week. Oops, can we go back one? Let's see. So basically, surgical education, what I gleaned from this was basically the residents, basically involved in development of the extensive perioperative plans. You try to promote their skills and you have postoperative discussions, but most of the time you're basically having just essential staff in the surgery. So basically the attending, and maybe you have a higher level resident, somebody who's picked to be able to do the case, but you're not going to have 2 or 3 deep in the operating room with residents. And so you have discussion around, before, during, and after. I think like in at Mike's place, when I did my fellowship, it was very interactive. The lights had cameras in them. I'm able to talk microphone. So even if I'm starting a case for him, he's in there, doing, whatever work, and he's going, hey, what are you doing in there? And, talking with me back and forth. And so you can do multiple things. You don't have to be directly in the surgery and still have an interactive course. You can have, the amphitheater full of residents, and they can talk and ask questions during the case. So I think a lot of the technology we've already instituted is actually very adaptable to this time for residents training. They talked about, virtual reality simulation, and then post-pandemic elective surgery surge, trying to prepare for that, basically try to keep everybody healthy, try to keep everybody developing their surgical skills so that when that does happen, you have ability to have the staff and the resident resources available to handle that. The clinical education basically is faculty only, and then basically it's need to be seen patients, but basically after the fact, the faculty does a virtual conference and talks with residents, maybe do case conference of what they saw in clinic that was interesting, and then ultimately some telemedicine, being a little bit more adept at doing telemedicine visits with some of the residents remotely. So basically, the main goal is to basically limit the virus spread, not only in the community, but within the residency, and then have the flexibility to kind of change as we go, adhering to CDC government regulations. And then, number one is make it sustainable, where we can, basically promote these residents through their education, continue to develop their skills and progress them. We don't want to have dead years where these residents are basically not being taught. I think everybody's seen that, where certain fellowships and that are being canceled. There's been discussion about extending some residency, time periods. So it'd be interesting to see what everybody has to say about this article.
Great. Any comments or questions?
This is Jens. So
while we're coming up with one, I did have to say, I did get a question on the previous article that I submitted and said, how come we're not discussing burnout among spine reps? Obviously that came from a rep, but I didn't really find it much value to answer. So tell Bill Sorello that he can just deal with stress on his own. But okay.
Oh, listen, Billy's the most laid back person in the world.
I think Jens is trying to say something.
yeah, I have to.
Jens, unmute.
Am I
Jens.
still muted?
You're on, Jens. Go ahead.
Yeah, so as an editor of one of our journals, I have to say this is an important article, but we are inundated with COVID articles. Anything COVID related kind of gets fast tracked right now, I think, by just about every journal. And universally, they have a lot of interesting observations, but no evidence or any meat to them. So that's my one caveat about all these COVID articles right now. And this is no criticism about selecting it. I think it's important that we talk about this. But I think what's happening in these virtual or Zoom communities is way more important in terms of that we kind of compare notes and have from LA through Indiana, through Denver, out to the East Coast and New York, comparisons, and can share our success stories and share our misery with one another. So this was the little editorial, but clearly focusing on our fellows and residents and making sure that they see ways of coping with a crisis is very important for all of us as attendings. And I think that's probably the key thing that I got out of this article. Thank you.
Patrick Johnson, do you have any comments on how you guys were managing your residents and your training during this this time frame? And have you gone back? Have you learned from that? And is your program going to do anything different going forward once we return to a new normal?
Well, Mike, thank you very much. I've been listening and kind of wondering where and how I could pipe up here, and these are good articles. And and kind of commenting on both of them is that the selection process of residents is something that I think is exceedingly important, and because these people are needing the right kind of guidance to be at the right place and make the right decisions in their life. And when we've all gone through our residencies, we've seen people that succeed and the ones that fail. And, I'm not sure that we're doing a great job, and I have a lot to contribute here, but we try and select people that not only have all the right criteria, they're great people, they've written papers, they got board scores, and they're accomplished in a lot of ways. But we try and look at them and ask them questions, and we talk about this as a faculty, maybe not enough, but we talk about, do they fit the criteria of what is going to stand up to the demands? Because the demands are still a lot the same as they were when we were residents. I mean, it's actually more difficult, I think, because life is more complicated. Medicine's more complicated. Everything we do is more complicated. The amount of information they need to learn. And so I think that it's kind of a quippy little saying, but we have one, we say, do they pass the 2 a.m. test? So when we're interviewing a resident, we think of it in that way and say, okay, if I'm going to get a phone call from this person and I'm on the phone with them, and now we actually can do visual information quite readily, but is this person going to be able to communicate to me what's going on with a patient that's in the emergency room and a trauma patient, or in the intensive care unit, or some problem anywhere? Do they pass that test? Are they going to be able to do it? And it's helping to select those people. Now, I have a worry about it, is that they may not come to our program, but what if they go to another program, or maybe they shouldn't go to that kind of discipline? I mean, something probably needs to be more structured. I mean, at the higher levels in the neurosurgery world and orthopedic world, is say, let's help people make the right decision. We know they want to come be an orthopedic surgeon or a neurosurgeon, but some of them just aren't meant to be. And I think that something along that line is important as the selection process. And what we're doing now is that we're doing this team approach. And I'm sorry to take up so much time here, and I'm answering a few different questions. But we're doing a lot of the team approach thing, is that we have teams and they're coming in, and we're utilizing all of this data and information, and we're having a lot of online and Zoom education and things like that. So adapting as quickly as we can in this world. And I think spreading that success around, it seems to be doing a good job, but I don't know, we'll see how the failures are. I haven't seen any real problems yet. Everybody seems to be coping with it pretty darn well, but how long is that going to last? We don't know. So those are my comments, and I'm sorry to take so much time, but I wanted to kind of contribute a few of them.
You did great. I'm going to ask one more question. How often is it that you have a resident that you think you do a good job of selecting them, and somewhere during that 5 years, or how often every 5 years, does a resident either quit or you discharge them and help them find another career path?
Well, we get one. I'm going to say it seems to be about 10%, to be really honest, is that we have somebody that we look at it and just say, you know what, we didn't make the right choice, or somewhere along the way we all failed. And that's pretty high. I mean, maybe I'm a little hypercritical, but you know what, we have a duty to society to produce people that are going to be responsible and are competent to be able to carry out the things that they need to be doing for society. Because when we unleash them out there and they finish their training, we're the ones that ultimately should have responsibility, but God forbid nobody's come back and taken action on us, when there's been problems. And we know we've all had them.
Jens, when you were at the university, was there a significant washout rate, or how did you handle residents that weren't making the standard, either by voluntary admission or by oversight?
A huge problem. I mean, this is not a resolved issue, and I think Patrick and others, I think, brought this up now. There's not a good answer, because especially in orthopedics, by about the third year, when you make it past that, it's exceedingly hard to redirect somebody's career. I found, having been so involved in neurosurgery programs, neurosurgery in general to be way better, and this is a longer residency, to kind of career counsel the young men and women who may not be a good fit for that. And so there's a little bit more leeway and a little bit more engagement with the fewer residents. I think one of the articles before raised one of the huge burnout risks, and that's very large programs. If you can kind of be in a program of 8 or so residents, it's very easy to kind of hide and duck under and get through your first critical 1 or 2 years. and then you're kind of passed through. So yes, we should have a far more stringent kind of an R2, R3 in orthopedics review process before people are kind of on the tail end of their educational career. Thanks for bringing that up, Jack.
There's one more kind of comment I'll make quickly, is that in neurosurgery, at the high levels of organization, they have encouraged, and we're doing it, is creating a mentoring program and doing it very early on. Either assign somebody, and that can change in the mid-level of their residency, but have a specific faculty member, and they can move it around as their career develops in residency or their residency training. But having somebody that, it's kind of like sitting down with your spouse for that 90 minutes. We can't do that every day, but we spend 90 minutes like every few weeks or something like that. And that's probably one of the more important things. And then you get where the resident can choose their mentor, and they say, I like this person. This is how I think I want to mold my career and where I want to go. And it may be in their discipline. But the mentoring process, I think, is a great one. And we've found a lot of success with that in helping residents and guide them.
Great. The next couple of articles were also part of, I think, some of the highlights that were selected by the American Board of Orthopedic Surgery for the MOC, and one was in blood loss management and one was in vancomycin. And so I thought we'd ask Stan Crawford from Phoenix to kind of give us this review article, just kind of, and just summarize some of the key points upon what we deal with and where the state of the art is in blood loss management. Stan?
Excellent. Yes, thank you, Dr. Janssen. So I'm Stan Crawford at Sonoran Spine Center in Phoenix. I'm going to talk about blood loss management and spine surgery. This is out of JOS 2018. Okay, so first we'll go over some pre-op considerations. And you can see this table to the right kind of goes through the medications, the half-life, mechanism, action, as well as the minimum time to cessation. So first we'll start out with anti-inflammatories. So pre-op anti-inflammatories, your non-aspirin discontinuation is really not well defined. And platelet function normalizes within 3 days for most of your anti-inflammatories. Aspirin, there was a POISE-2 trial which said that aspirin had no significant effect on the rate of death or non-fatal MI, but increased the risk of major bleeding. As far as the spine literature, there's no evidence in the spine literature of increased blood loss when comparing those that never took aspirin versus those that stopped aspirin within 3 to 7 days prior to surgery. Stopping aspirin can cause negative cardiac and thrombotic events, though. So moving on to your platelet inhibitors, premature discontinuation of antiplatelet therapy, including aspirin, has emerged as one of the most powerful independent predictors of stent thrombosis. So the current recommendations for these stopping platelet inhibitors are no elective spine surgery within 6 weeks for bare metal stents and then 6 to 12 months for drug-eluting stents. The CHEST guidelines suggest that continuing antiplatelet therapy perioperatively if surgery is required during this early period of stent life. So moving on to your long-term anticoagulation. So Coumadin, warfarin, DC 5 days prior to surgery and restart immediately after surgery. The high-risk patients should be bridged pre- and post-operatively. Your low molecular weight heparin should be DC'd 24 hours pre-op. Your unfractionated heparin should be DC'd approximately 4 to 5 hours pre-op. And then you can restart your low molecular weight heparin or unfractionated heparin 2 to 3 days following spine surgery. And then your factor 10A inhibitors should be DC'd 3 days pre-op, 2 to 3 days pre-op as well. And the article does recommend stopping all supplements 14 days pre-op, and it also said that about 25% of patients undergoing surgery are taking some form of supplements. So moving on to autologous blood donations, they really recommend against this heavily. So it potentially creates iatrogenic anemia, can create increase in postoperative transfusion rate. The blood may go unused, which is a waste of resources and money. They say that about 33% of patients never even receive their donated blood, and then approximately 25% still receive allogeneic blood. So moving on to your cell salvage. the indications are high expected blood loss, greater than 500 mLs, patients with religious beliefs that preclude allogeneic products. The recovery rate of RBCs is about 38 to 40%, and that to increase this, they recommend using open tip suction with pressure less than 100, fewer sponges, rinse the sponge to collect the RBCs, avoid blood pooling and clotting, and then limit antibiotic irrigation, water, iodine, and solution warmer than 42 degrees Celsius. So for cell salvage, it's contraindicated in malignancy and infection. There is a risk of transient hemoglobinuria, pulmonary complications from reperfusion, and then potential coagulopathy. And then they recommend for every 1 liter return that you get 1 unit of FFP should be given. The anesthetic techniques. So we'll start with hypertensive. There's research in pediatric scoliosis that's shown that about 55% reduction in blood loss. And then concern for end organ perfusion with this, including spinal cord and optic nerve, as we know. Core temperature control is important. Hypothermia most common during the first hour of anesthesia. And then mild hypothermia can cause 16% increase in blood loss and up to 22% increase in risk of transfusion. Control body temperature with blankets and skin exposure. Moving on to antifibrinolytics, your Txa and Eaca. So these are lysine analogs that inhibit the binding of fibrin to plasmin or plasminogen. There has been in vitro data showing reduction in osteoblast bone mineralization, but no such evidence in vivo studies. So I know we use primarily Txa here, so I'll kind of go into to that more in detail. So 60 times more potent than Eaca. The loading dose is 10 milligrams per kilogram, and then 1 milligram per kilogram per hour infusion dose. Proven benefit in AIS and adult spinal deformity. There is no evidence showing increased thrombogenic nature. Rotational thromboelastometry. This is a rapid method to test deficiency in coagulation pathways. Platelet adhesion, aggregation, clot strength, and fibrinolysis in whole blood during surgery. Reduction in amount of blood products needed and reduced cost when this is used. Patient positioning. Recommend reverse Trendelenburg for decreased central venous pressure, and then obvious appropriate pad position to relieve pressure off the abdomen. So surgical techniques, including dissection. So use of local with epinephrine prior can reduce bleeding, bipolar and monopolar electric cautery. And then saline irrigated bipolar, like Aquamanus, can cause contraction of vascular collagen at temperatures less than 100 degrees Celsius. So this is just a table that I won't go over, but it kind of talks about the topical hemostatic agents, bone wax, Surgicel, Flow-Seal, Tza, and those sort of things. So good table to refer back to. And go over post-op considerations. So first is drains. There's a potential increase in post-operative blood loss with the use of drains. Diab found increased transfusion rates in idiopathic scoliosis patients with postoperative drains, 43% versus 22% when drains was not used. There was a 2016 meta-analysis that showed no difference in post-op blood loss whether post-op drain was used or not. Ketorolac, there was a meta-analysis of 27 randomized controlled trials that found no significant increase in post-operative bleeding with Ketorolac versus use compared with controls. And then moving on to allogeneic blood transfusion. Transfusion requirements in critical care clinical trial showed no difference in overall mortality between a most restrictive transfusion threshold of 7 versus a more liberal of 10. The current restrictive threshold for blood transfusion is a hemoglobin of 7. Patients with cardiovascular disease are at increased risk and should have a more personalized transfusion threshold, typically a little greater than 7. Thank you. That's it.
Concept of mentoring is important in our field. But how do you actually do that? Because if you just assign a mentor, their personalities, their lifestyle, and things don't match, and people tend to gravitate. So I guess I wanted to ask Ezzy and Jack and Rich and Scott, all from the same institution. You guys have 4 or 5 fellows a year. How do you end up mentoring them, and who bonds with them to kind of give them the best advice on where they should be going with their career and help? Or do they just gravitate towards an individual faculty that they're working with? And I think once there's 4 of you from the same institution, you could give us some great insight on how you do that.
Mike, fortunately, we don't have a formal mentoring program. And what happens is the fellows will gravitate to one of the docs they rotate with and sort of bond with them. And, then you give them the advice that they seek. And we've not really have found the need for a formal mentoring, but it's something that certainly we should consider. I like to hear what Jack and Izzy say and Scott.
One of the things that I've noticed over the years, I was the product of a one mentor, one fellow program when I did my fellowship, and it was very, very different. And I saw others around. I had the privilege of working with a great mentor, and I saw others that were training at the same time of me. And one of the things that I realized is you can also learn from not a good mentor. You can learn how not to be a surgeon or what type of surgeon you don't want to be. I think right now at TBI, we've got a very well-balanced program, and all our fellows have different personalities, and all of us have different personalities. And I think invariably every year, 1 or 2 bind with each 1 or 2 of us that come around. And those relationships last a long time. I still speak to a lot of our former fellows, as I'm sure my colleagues do. And we hear about their life events, their balance between work and life, and we hear about their terrible cases, and they call us for advice about upcoming cases, and the network just continues to grow. So I don't think the mentorship stops as soon as they leave fellowship. I think it becomes a lifelong relationship.
Yeah, I don't have anything to add to what Izzy says. I totally agree. And, when much like what Izzy said, also in my training as a resident, very early, I gravitated towards one of our faculties, passed away since then, Dr. David Selby, and we ended up lifelong friends, not even in the same practice in the same city. And like Izzy said, it comes from more from the resident or fellow, I think, than a formal program.
Todd, do you have anything to comment on how you guys deal just quickly with mentoring and trying to give good guidance to the residents and the fellows specifically?
It's really not different than what was said already. I think it's really up to the individual fellow and mentor. They make the bond, and they both have responsibilities. But it just seems that organically people gravitate to each other. And I've had a number of fellows over the years that I've become incredibly close to. Some became my partners, some didn't. But I think it becomes a little bit organic, and the fellows end up making the choice. We don't have necessarily a program, but we have an apprenticeship model where there's rotations where you work with one person, so people get the ability to get into that mentorship mentee model.
The structure of these things is that we have a residency program and a fellowship program with a lot of people in it. And there's built into the scheduling of it that is natural dispersion of the mentoring, that residents are assigned to different services. So by order, they get to have different mentors from different disciplines and somebody that they may not necessarily choose. Our fellowship program has a similar kind of scheduling structure. So you naturally get to be with everybody, but then people will gravitate. It's in the residency program where we actually have an assigned mentor program, which we don't do that in our fellowship program. I'm not sure we need to in the fellowship program because, that's postgraduate training is what it is, and they've already selected that they're going to be a spine surgeon. So they gravitate to all of us. And so having a mentoring program there is probably not necessarily, it's just by nature of the rotations do they get mentoring from each and every one of the guys that are on our faculty.
We've got a bunch of our fellows on the line. Mike Heisey actually just suggested that on the chat line. Can we hear from one or two of them, give them a minute or so to see from their perspective?
Now there's 24 of them.
Yeah.
We're chats down there. Pull up some of those. They'd be good, rather than listening to us.
Yeah, you know how to get them on?
John Burleson, watch on mute. I don't hear Mike. John?
Can you hear me?
Yep.
Yeah, so I mean, I'd agree with what some of my attendings here have said. I think it's pretty informal for us, and at least for me, I like it that way. We work with really everyone. I think we have 19 surgeons here. I think I've done at least one case with everyone, and pick 2 or 3 people that I probably communicate with more about not just really the operative stuff, but more building a practice. What should I be concerned about with building a team where I go? And then, personal interests. I'm interested in a lot of, 3D printing and device stuff. So certainly plenty of people at TBI that have helped with that can kind of guide me so I don't feel like I'm going to get swindled somewhere in my career and, kind of meandering through the ethical dilemmas of getting involved with different things. And so for me, it's been great. It's just conversations after the OR. I mean, I can't tell you how many times I've stuck around for an hour after a case and just kind of discussed with the bosses, how they feel about different things. So it's been just an organic process that wasn't assigned in any way. And at least for me, I really prefer it that way.
Great. Let's we have a couple of quick questions. One I got that said, I do anterior surgeries with sub-Q heparin, and if I do not open the canal, I start the sub-Q heparin right away in the PACU. Does anyone have any comment on why, if they don't do any intracanal work, is it safe to start the sub-Q heparin right away? Patrick, any thoughts on that? We don't have you yet, buddy. Hang on.
I don't distinguish between the two of them, but it's an interesting concept because, the front of the spine doesn't bleed as much. I mean, you can do almost anything regardless of what kind of anticoagulation probably, or with not as much vigilance. I get on the posterior side and inside the spinal canal, it always bleeds a lot there. And, just from my own personal technique side, there's one thing that I learned and I think made me a better surgeon is I quit using the bipolar as much as possible. Okay, I just use gel foam and pack things and I move on and I do something else. And you can waste so much time with a bipolar. I mean, with all due respect to my neurosurgeon friends, I say to them, that a bipolar is a neurosurgical waste of time, except for brain surgery. And it really is inside of the spinal canal. Unless you can see something bleeding, just pack it with a little gel foam and move on and go somewhere else because it'll stop within about 30 seconds.
Can we quickly do this Vancomycin study? I think this is very interesting. Is a quick study, and I think Dr. Ottemeyer is going to share her thoughts with us on this one.
Great. Thank you so much for the introduction here. Oops, we missed the first slide.
I think it was just a title slide.
Title slide. So this was an article, I can just tell you about it, that came out of the Spine Journal in 2018. This is one of the tested articles that Dr. Janssen was referring to in the ABOS this year. It's out of Japan, answering and asking the question, really, does interwound vancomycin powder reduce surgical site infections after posterior instrumented spinal surgery? So just as an introduction, surgical site infections are associated with a higher morbidity, mortality, and overall healthcare costs of a procedure. They occur overall, the rate varies between 0.6 to 12% in patients that are undergoing instrumented spinal surgery. Staph aureus and epidermis are the most common organisms associated with these. Interwound vancomycin, in theory, could reduce the frequency of these infections, killing gram-positive cocci. However, the results of previous published studies have been overall inconsistent and inconclusive. So the design of this study was a multi-center retrospective cohort with propensity score matching. They selected all spinal surgeries performed at 11 hospitals over the course of 2 years. This included all posterior instrumentation cases, so cervical, thoracic, and lumbar. Patients were over 15 years old and had a minimum of 1 year follow-up. So in their methods, all patients in the study received the standard pre-op and post-op IV antibiotics. Patients were grouped into two cohorts. Basically, the vancomycin group, the folks that did get interwound vancomycin, either 1 or 2 grams, versus the patients that did not. The decision to use vancomycin and the amount was based on surgeon preference, essentially. In their analyses, they did 2. They grouped them as a whole cohort, so all the patients, and then they did a matched cohort analysis. So they did 1-to-1 matching model using propensity scores. I listed the table up here, which are variables they looked at to calculate these scores and match patients. They were based on patient characteristics and operative details. So in their results, they separated these into the whole cohort results and then the match cohort. So in the whole cohort, 25% approximately received the vancomycin powder, about 75% did not. It showed that patients that did receive the powder were significantly older. They had more medical comorbidities, diabetes, and chronic kidney disease. They're more likely to have had previous surgeries at the same site, longer surgeries, greater blood loss. In the whole cohort, the vancomycin group actually had a higher SSI rate, likely because of the reasons listed above, where that wasn't significant. This is essentially a summary that demonstrates that the vancomycin group had overall higher incidence of diabetes. They were older, and like I listed before, surgery at the same site, higher blood loss, and operative time. The match cohort is really hopefully where we would get our better data. They found 507 pairs of patients. However, there was no difference in the SSI between these groups of matched patients, between vancomycin and the control group. Additionally, they did an analysis of the organisms that they found in the infections. There were a total of 26 pathogens and 33 surgical site infections. The most common organisms were Staph aureus, both sensitive and resistant, as well as coagulase negative staph. There was no species rate that was significantly different between the two groups. However, the rate of gram-negative rods was higher in the vancomycin group, which was not statistically significant. And this is just the graph that they demonstrated that showed in the control group on the right that there was a higher overall incidence of staph species compared to the vancomycin. So I'll skip this and go back just to look at our limitations of this study. Overall, there are significant limitations to this. It did not record the amount of the vancomycin used. It was either 1 or 2 grams. Additionally, they didn't record history of factors that may be associated with surgical site infections, coronary artery disease, COPD, osteoporosis, or general surgeon experience. It was a retrospective study, which there's inherent limitations there. There were no patient-reported outcome scores, and overall it was a relatively small sample size for the incidence of infection being overall, as they reported 0.6% in some cases. Only having a cohort of 3,000 patients may not have been enough to actually generate some data. And then if I could go back here. So in summary, recently there has been a marked increase in the use of interim vancomycin following a publication by Sweet. However, data since then has been conflicting. There have been 3 meta-analyses that showed a decreased rate of surgical site infection with the use of vancomycin. However, 2 randomized control trials showed there was no difference. So this is just a study that is being tested this year for us to read, but it reveals that there's no significant decrease in surgical site infections with the use of vanc.
I think the exciting part. Thank you, Christine. That was great. Let's see here if I can get it up. Hello? Okay. I think one of the keys of this article for me is that it was, there was no difference. It was a large volume of patients, but again, that there was not much difference whatsoever. But I think it'd be interesting to pool everybody here on who routinely uses vancomycin intraoperatively into their wound.
So at one point, a number of years ago, I did, and I was involved in one of the multi-center trials, which showed that there was a very slight decrease in rates. But I found a lot more wound seroma issues. And then at one of the meetings, I saw a paper, and I forget the lead author, it was from Germany, that showed the dose of vancomycin in the wound actually inhibits the osteoblasts, and we're trying to get a fusion. So I just completely abandoned it on the basis of the seromas and the potential biologic effect of that high dose of vancomycin. And I haven't regretted it, so I haven't gone back to it.
This is Jens. So this is a great article. Thank you for bringing that up, Christina. You already pointed out the great weakness. Here in Washington State, we have the state spine database scope, and we had such high hopes that we could answer questions like this. And the first thing you brought up, when we did a power calculation, we identified that the minimum number, due to the vast number of variables that there are, is probably about 20,000 patients. The second thing is that in every single attempt at trying to assess infections correctly, the rate of loss to follow-up is a very important confounding factor, such as difficult tangents like hemostasis at the conclusion of surgery and healing potential factors on the part of the patient. The point is that this needs to be prospectively assessed. This would be something where a large prospective effort is required to answer this question. So all these retrospective studies that are shy of about 10,000 and that are well controlled with a very low loss to follow-up rate are probably not helpful. The thing that Izzy brought up is a very important one, and that is there an adverse effect to bone healing? Is there a problem with dural scarring, for instance? So some of our neurosurgical colleagues could possibly address that. Is there a problem with putting the vancomycin powder directly on exposed dura? But the bone healing part and the risk of pseudoarthrosis has not really been addressed in vivo and only been looked at in animal models, and there it's had an adverse effect. Thanks.
Fantastic. We had a question that, is there a NAS? Does NAS have a positive position statement for the use of vancomycin to reduce spinal cord infections? And I can't answer that. Does anyone have any information on what NASA's position is on that? And do they have a positive position on that? I'm sorry, I don't know the answer to that. That was a good question. Any other questions or comments regarding this concept of vancomycin? Dr. Dorenkamp in Michigan has a short presentation on that he'd like to do, and then anyone that can stay, we can add any. I think we got a great amount of discussion today on the managing of stress in the orthopedic family, and Rick Sasso just joined us because he finished as a psychiatrist, so maybe he can tell us a little bit how he's doing. Okay, let's go.
All right, thank you. I'll make it quick, seeing how we're running low on time. My name is Clay Dorenkamp. I'm a fifth-year orthopedic surgery resident here in Lansing, Michigan. I'm going to be doing a one-year spine fellowship with Dr. Janssen at the Center for Spine and Orthopedics at the end of July. And looks like I selected the comment. There we go. So the article I selected was from the Journal of Spine, published in 2020, looking at postoperative kyphosis in cervical spondylitic myelopathy in patients undergoing laminoplasty. This was published in Japan. The purpose of this study was to determine the relationship between preoperative sagittal balance of the cervical spine and postoperative kyphosis in patients undergoing laminoplasty. And really the goal of the study was to determine the cutoff angle for predicting the post-laminoplasty kyphosis. So to do this was a prospective cohort study. It was level 3 evidence. Ultimately, they started out with 1,596 patients, but after exclusion criteria, had 1,025 patients and had 93.3% follow-up. They did use the modified double door laminoplasty method as illustrated below. Their exclusion criteria, I won't go through all of them, but the ones I did want to point out is they excluded anybody with OPLL, and they excluded patients with severe kyphosis more than 15 degrees. I did think it was interesting that they allowed patients with up to 15 degrees of kyphosis to be included in the study. For the radiographic analysis, they did pre-op and post-op measurements of neutral and maximal flexion extension, and they set their lordosis for patients that were considered lordotic to having a lordotic angle greater than 0 degrees, and patients that were considered kyphotic for patients less than 0 degrees. So this is kind of an overview of their patients. Over 911 patients had lordosis preoperatively, and 5.3% of those patients ended up developing kyphosis. 114 cases of kyphosis were noted preoperatively, and 46.5% of those cases were still kyphotic postoperatively. This is just an overview of the demographics of the cohort. Overall, it was a well-matched cohort of patients. The only real difference in the patient populations was that the lordotic patients were slightly older than the kyphotic patients. Their statistic analysis, they used the ROC curve and looked at the area under the curve as well as the Uden index to determine their cutoff. And these are just graphs showing and the area under the curve. And ultimately, they ended up breaking into 2 groups. One, they looked at all patients in the study, and 2, they looked at patients where they excluded the kyphosis, so only lordotic patients. For all patients, they determined a cutoff of less than 6.5 degrees to be a risk factor for developing kyphosis, noting that 26.2% of those patients developed postoperative kyphosis. And when they excluded kyphosis, they set their cutoff for 7 degrees and noted that only 14.7% of those patients ended up developing kyphosis. And if the cutoff was greater than 7 degrees, then only 2.8% of those patients ended up developing kyphosis. This was just another chart showing the demographics with the kyphosis excluded. Overall, when you looked at all patients, if they had a lordotic angle less than 6.5 degrees, they had a 26.2% chance of developing post-laminoplasty kyphosis. And if when they excluded preoperative kyphosis less than 7 degrees, had a risk factor of 14.7% chance of developing post-laminoplasty kyphosis. Overall, kyphosis was observed in 48 patients in the lordosis group, or 5.3%, and kyphosis was noted in 53 patients. 53 patients in the kyphosis group continued to have kyphosis postoperatively. Limitations, they didn't compare the cervical alignment with overall sagittal balance of the patient, but I think more importantly, this was strictly a radiographic study, and they didn't report any neurologic or pain outcomes, which I think is an important thing that we need to consider in our patients postoperatively. Also, they measured each of their x-rays multiple times, and they didn't report any inter or intra-observer reliability. Overall, I think this was a large, well-powered study. I think that this adds good clinical information to us that if you have less than 7 degrees of lordosis in your cervical spine, that you're at significant risk for developing a postoperative kyphosis if you undergo laminoplasty.
Hey, Clay, I would just qualify that by saying if you're undergoing a double door laminoplasty without instrumentation, this probably represents your risk, but that's not an operation that I think many of us do. So I'm just not sure, for me, whether this is meaningful, whether it's information I can use, because it was every single patient was done with that same technique. And I think most of us here use an open door with hardware now, and postoperative kyphosis with that construct, I think has been a lot more rare than we've seen before. Mike, would you agree?
I would agree. Yes. Yes, I would agree. And I would also say, is that within the measurement, of measuring 7 degrees of the total cervical lordosis in the first place makes it somewhat of a challenge to make that as a benchmark.
Well, thank you, Mike. You put together a great bunch of articles, and I love the discussion on the stress. That was something I think we all need to hear and talk about every once in a while. So your team did really well. Thank you.
Well, thanks.
And for those of you that don't know Mike very well, Mike is the opposite of Burnout. He is the true Renaissance man. So everybody have a great weekend, and hopefully we'll get back to normal.
Thanks. Memorial Day. Thanks again. Barbecue some meat.
Great session, Mike. Thank you very much.
Thank you.
Thanks for watching. Hit the subscribe button for for more medical content,